about contributing sufficient and necessary causes. Maybe the Nordic welfare state is not a sufficient determinant of a good health development and low income inequalities, but Michael has been an absolutely necessary cause without which nothing would have happened the last 5 years. So please, Michael, you have to take the floor.
Well, thank you, and it's an absolute pleasure to be here, and such a nice introduction. I hope you know that there was a WHO Commission on Social Determinants of Health, which I chaired. We produced our report in 2008, and we called it Closing the Gap in a Generation. It was a statement that we actually have the knowledge and the means to close the health gap in a generation. The challenge that we put forward was, do we have the will to close the health gap in a generation? There's been action in a number of countries. My own, I was invited by the government in Britain to ask the question of how the findings and recommendations of the WHO Commission could be applied in one country, in the UK. I produced my report last year, and we called it Fair Society, Healthy Lives. It was a statement that if you put fairness at the heart of all decision-making, health would improve and health inequalities would diminish. Zsuzsanna Jakab, who will follow me onto the platform, invited me to conduct a review of social determinants in the health divide in Europe. She asked, how can the findings of the Global Commission be applied in a practical way to the 53 member states of the European region of WHO? We've produced an interim report, and we will produce our final report next year. And as Dr. Jakab, I'm sure, will say, it will feed into the process that she launched of Health 2020. Unusually, perhaps, for a publication that had the imprimatur of the World Health Organization, we said that health inequalities arise from a toxic combination of poor social policies and programs, unfair economic arrangements, and bad politics. On the back cover of our report, we said, social injustice is killing on a grand scale. And I'll come back to the sensitivities that might have aroused before I finish. The broad European context, we have the health divide between countries. No doubt you've seen figures like this before. Life expectancy for women in Kazakhstan, 73, in France, 85. A 12-year gap across Europe for women, and a 20-year gap for men. In the Russian Federation, life expectancy for men is 60, and in Iceland, it's 80. In Switzerland, it's 80. So we have these huge, huge differences among countries. We also have huge differences within countries. Our chair said at the beginning, there may have been a successful welfare state in Denmark and the other Nordic countries, but still there are big inequalities. Espen Andersen earlier this afternoon gave what, in my humble opinion, was a brilliant presentation. He actually started by saying it wasn't relevant to public health, but I think it was highly relevant to public health, what he had to say. And as I said to him afterwards, I only differed with him on one point, which was, he said the key issue is poverty. He said there's a non-linear relation between economic position and health. That's not what the data show. The data shows something quite different. This is England, but I could show you things from Uganda, from India, from Peru, from virtually every part of the world, showing the social gradient. The top graph is life expectancy. Each of these points represents a small area of England classified by income deprivation. And what you can see is that people near the top have shorter life expectancy than those at the top. People in the middle have shorter life expectancy than those near the top. It's a gradient all the way from top to bottom. The gap between the 5th centile, the most deprived, and the 95th centile is 7 years on average. But the drama here is not the gap between top and bottom, it's the slope, it's the gradient. The bottom graph is disability-free life expectancy. The gradient is steeper. The gap between the 5th and the 95th centile is now not 7 years, but 17 years. And that means that people at the top are living 12 years of their lives on average with disability, and people at the bottom are living 20 years of their shorter lives with disability. And I've been making the case to government that they should take action for moral reasons, but in case I can't convince government to act for moral reasons, that there's an economic case. This green line represents the plans of the previous government in England to advance pension age to 68 by 2046. The present government wants to do that more quickly. That's the top of that green line. Were pension age today 68, you can see that between two-thirds and three-quarters of the population do not have disability-free life expectancy as long as 68. If the effect of prolonging working age to 68 were to move people off pension onto disability benefits, that would be a dubious social advance and save no money. So my argument to government is you have to take action across the whole social gradient. This is not a matter of focusing simply on the bottom, on the worst off. You have to address improvements in the whole of society. Johan Mackenbach has looked at these gradients across Europe, and as a way of summarizing the gradient, he used the slope index of inequality. And you can see that the gradient's steeper in Hungary, Lithuania, Estonia, Poland, Czech Republic, and Slovenia compared with the European average, and it's less steep in Spain, Sweden, Italy, etc. So we have these bigger inequalities at the east of the region than we do in the west and the north of the region. In the review that I was asked to conduct in England, we had 6 domains of recommendations, building on the findings and recommendations of the Global Commission. Give every child the best start in life. Enable all children, young people, and adults to maximize their capabilities and have control over their lives. Education and lifelong learning. Create fair employment and good work for all. A healthy standard of living for all. Create and develop healthy and sustainable places and communities. And strengthen the role and impact of ill health prevention. And I'll give you just a few examples of some of the evidence and recommendations underpinning that. So very much we took a life course approach. In taking a life course approach, it's important to emphasize that it's not all over with early child development. There's much you can do to improve the situation of older people, of people of working age. And indeed, because it's cyclical, looking at family building, that impacts on prenatal influences, preschool, school, and so on. So a life course approach means, yes, starting at the beginning of life, but acting at the various key stages of life. So an example from the early years. In Britain, this has now become known as that graph. These are data from the 1970 British birth cohort, following children from 22 months of age to 10 years of age, looking at cognitive development. So look first at 22 months at children who were in the 10th centile of cognitive development. If they grew up in families of low socioeconomic status, they remain low. There's regression to the mean, but that's not the key issue here. If they grew up in families of high socioeconomic status, they catch up. Look at the other end. Children who at 22 months were in the 90th centile on cognitive development. If they grew up in families of high socioeconomic status, they remain high. But if they grow up in families of low socioeconomic status, their relative ranking declines. Let me be really crude. If you're smart and rich, you stay smart. If you're smart and poor, sorry, won't do. If you're dumb and rich, then just hang in there. It'll come out all right. But if you're dumb and poor, I'm sorry, it's not going to work for you. Now, this starts right at the beginning of life. Why am I showing you this to a public health audience? Because what happens in early child development influences what happens in the school system, and that influences whether you get a job at all or the kind of work you do and your income and where you live, and that in turn has powerful influence on health and health inequalities. And in looking at this, paying attention to the geneticists, I say assume for the moment that all the differences at 22 months are biologically determined. Genes, birth trauma, things of that nature. And the differences associated with socioeconomic status of family are socially determined. The social trumps the biological. Now, not all the differences at 22 months are biologically determined. The quality of rearing, nurturing are vitally important. One measure here, reading to children every day. It follows the social gradient. The evidence from Canada suggests that half the deficit in readiness for school associated with low income can be reversed by reading to children daily. And reading to children daily follows the gradient. We've looked at other measures of parenting. They all follow the gradient. Cuddling children, talking to children, playing with children, singing to children, all follow the social gradient with profound impact on physical development of the child, on cognitive and linguistic development of the child, and on social and behavioral development of the child. School, yes, of course. Let me skip to employment and work. The nature of the employment contract is important. This is looking at mental health in workers with no contract, with a non-fixed term temporary contract, and then fixed term temporary or permanent. And sorry, the gender got left off, men and women. People with a non-permanent contract, job insecurity, have worse mental health. And what happens in the workplace is important. We've been looking in our Whitehall 2 study at the stressful work environment, isostrain, being socially isolated, high demands and low control, and in a longitudinal study, asking people on 1 exposure, 2 exposure, 3 or more exposures to adverse working conditions. The more exposures to adverse working conditions, the greater the likelihood of the metabolic syndrome, which of course is associated with increased risk of diabetes and of heart disease. And unemployment relates to education. This looks at unemployment for people with low education, with upper secondary and tertiary education. In all of these countries, you can see that when there's an economic downturn, it doesn't hit people randomly. The unemployment's much higher the lower the level of education. Healthy standard of living. It's interesting that when the government of Britain picked up the review that I did and featured it in the Public Health White Paper, something which delighted me, that the government should say, we want to put health inequality reduction at the heart of our public health policy, and we need action on the wider determinants of health. And they picked up 5 of my 6 recommendations. The one they didn't was minimum income for healthy living, which matters. David Stuckler and Martin McKee have a program of work, and this is just one example of the important work they've been doing, looking at relation between social welfare spending and all-cause mortality in 18 EU countries. The greater the social spending per capita, adjusting for purchasing power on social welfare, the lower the mortality. And they've shown trends in spending relate to trends in mortality. Esping Andersen earlier today showed you something similar to this. It's looking at child poverty before and after transfers, taxes and benefits. So down here we've got Romania, Bulgaria, Italy, Latvia, Spain, the UK, and up here we have Denmark, Norway, Iceland. And you can see that you get about a 70% reduction in child poverty from the tax and benefit system in the Nordic countries, and a much lower reduction in these other countries. Poverty levels are a result of government policy. The poverty level can be changed by government policy. The Minister of Finance is, or should be, involved in ethical deliberation about what we want the poverty level to be. And as Esping Andersen showed us earlier, these are European countries. In the US, the effect of tax and transfers is to reduce poverty levels by about 25%. Clearly, they've decided to organize their affairs to tolerate high poverty levels. Percent reporting bad health by social protection expenditure. The higher the social protection expenditure, the lower the proportion reporting bad health. Latvia up here. Latvia is interesting. It's being hailed as a wonderful example of how austerity can reduce the deficit. So we should all be like Latvia. 18% unemployment. 10% of the Latvian population emigrated to get away from these nasty policies. That's a wonderful success. They reduced the budget deficit, and 10% of the country said, we're out of here. And the other 18% who are unemployed, what a wonderful policy success. Sustainable communities and places. We've said how important the area is in a whole variety of ways. This year we produced a report on fuel poverty. Fuel poverty is having to spend more than 10% of household income on heating your home. Having to spend, that is, heating your home to adequate standards. You may decide to have a cold home and to eat, or not eat and have a warm home. People in poverty in a rich country like Britain have to make those choices. Now, there are 3 causes of fuel poverty, not difficult. Poverty, price of fuel, and the quality of insulation of the home. This is fuel poverty by income quintiles, and you can see the very clear relation. The poorer you are, the more likely you are to be in fuel poverty. And still in Britain, The year before last, there were 33,000 excess winter deaths, which are clearly linked to living in cold homes. 40% of those excess winter deaths are cardiovascular, a third are respiratory. And morbidity, respiratory problems in children, mental health problems in children, educational attainment. The current chair of council of the British Medical Association, who's from Scotland, who said, I know he didn't, but I can't get his accent. He said, when I grew up, there was ice on the inside of the windows. You can't tell me growing up in a cold home is bad for children. I said, imagine what you might have achieved if you'd grown up in a warm home. And we could solve this problem. This is a coefficient of seasonal variation in mortality. Finland, Germany, Netherlands, Sweden, Norway, Denmark, low. The UK, Ireland, Portugal, high. Roof insulation, it's high, but look at floor insulation. 4% in the UK, 100% in Sweden. Cavity wall insulation, 25% versus 100%. It's not difficult. Do we have the knowledge? We have the knowledge, we have the means, and somehow we can't do this. We just tolerate 33,000 excess winter deaths. But I'm absolutely excited. We had the first World Conference on Social Determinants of Health in Rio de Janeiro. People asked me, was it good? And I quoted Dr. Johnson, when a dog walks on hind legs, you don't ask, is it doing it well? You're just amazed it's doing it at all. It's wonderful that we had this World Conference. I was told it's the biggest conference WHO has organized outside Geneva since Alma-Ata in 1978. 128 countries represented, 60 ministers, 1,200 people talking social determinants of health for 48 hours. Now, what some ministers think as social determinants of health is making sure you can get to see a doctor. I have a slightly broader conception of social determinants than that, but nevertheless, talking the language. There's a Rio political declaration. I'm absolutely delighted. It doesn't have everything. The medical students, IFMSA, the International Federation of Medical Students Associations, put their finger on it. They said, what a pity. The main problem of the Rio Declaration is that it failed to explicitly tell us, I wouldn't allow my students to split an infinitive, but I'll let that pass, to explicitly tell us how the unfair distribution of power, resources, and wealth will be addressed, especially by member states. I don't think this was a casual lack. I don't think absent-mindedness is responsible for this not getting into the declaration. I think there was some significant resistance to the idea that equity, power, money, and resources are responsible. And indeed, we have them. These are data from the UK. The solid green line is the percent of pre-tax gross income plus benefit enjoyed by the top 20% of earners. It was about 37%. Under Margaret Thatcher, it went up to 42 or 43%. John Major, Tony Blair, Gordon Brown, didn't matter who the Prime Minister was, it stayed there. The bottom 20% had about 9% of total household income. That went down to about 6% and stayed there. The dotted line is the effect of taxation. Can you see an effect of taxation? No, me neither. I'm a simple doctor. What do I know about fiscal policy? If you'd asked me, I would have said we had a progressive taxation system. We don't. At best, we have a proportionate taxation system. Actually, it's worse than that. We put in our report that the top 20% pay 35% of their income in taxation, and the bottom 20% pay 38%. I think that's unfair. I think if you put fairness at the heart of all policy making, you wouldn't do that. That's unfair. And I say to American colleagues, you wouldn't do that in the US, surely. Well, wouldn't half. Look what's happened to the 50th centile of earners between 1970 and 2005. Scarcely changed. Look what happened to the 95th centile. Doing very nicely, thank you. Now let's look at the top 1%. In 1928, 1929, the top 1% had 23% of total household income. The top 1% of earners had 23% of total household income. And you know what happened next, 1929? Well, they brought the whole system crashing down with them. In 1978, the top 1% still had only about 8% of total household income. Parenthetically, I should point out that the American economy grew very steeply through this period when the rich were rich, but not fantastically so. And then, from the late 70s, the share of total household income enjoyed by the top 1% grew so that by 2007, they had 23% of total household income. And you know what happened next? Now, I'm a careful scientist. Correlation is not causation. I would never suggest that this proves that the unconscionable greed of the top 1% brought the financial system of the world to its knees. But it's a plausible hypothesis. And do you know who's paying? You are. We are. I scratch my head. I just can't figure this out at all. We get casino capitalism. We get these bankers who you wouldn't let into your local card game playing the way they play. They bring the whole system to its knees, and we, the taxpayer, bail them out. In Britain last year, we had, the last 12 months, 5.2% inflation. Average salaries went up by 1.2%. That's 4% less than inflation. And executives in the top 100 companies had a 49% increase in their salaries. Is there something I'm not getting here? Why are we doing this? Isn't this rather important to address these inequities in power, money, and resources? The people whose health is suffering are the ones who are paying for this through their tax system. And it matters for the next generation. This is a simple metric. If the income of parents exactly resembled the income of offspring, you'd score 1 on this metric. If there was no relation between the income of the offspring and the income of their parents, you'd score 0. So it's a measure of social mobility. Here, Denmark, very little relation between the income of parents and the income of offspring. So who your parents, or how much your parents earned, has not a very big effect on how much you will earn. We actually, I love to tell my American colleagues, have more social mobility in the UK than the US. That class structure in the US, it's all that inherited class that's freezing everything. The issue is that the greater the income inequality, the greater the gap between the rungs of the ladder, the harder it is to get from one rung to the next. So income inequality is not just affecting the current generation, it's affecting the next generation, their chances of getting up there. The reason I'm showing this again is I don't want to leave you the impression that I'm somehow annoyed, angry, pessimistic. I'm optimistic. We're on the agenda. We've got 128 countries discussing this. We've got the medical students of the world discussing this. We've got the public health people discussing this. We, on the side of the angels, are making progress. And by golly, we're really going to do it. And we're going to do it because what we're doing is in the spirit of social justice. We believe in empowering people. We believe in creating the conditions to give people freedom, to give people control over their lives. When we launched the Commission on Social Determinants of Health, I quoted Pablo Neruda, and I quoted him again in the English review, and let me remind you what he said. Rise up with me against the organization of misery.
Thank you very, very much, Michael Marmot, for this very inspiring speech. With such inspiration, I don't think there's any excuse not to follow the calls from the Rio Declaration and also the World Health Assembly in 2009 for national local governments to try to deal with these issues. So thank you very much. And I will invite Zsuzsanna Jakab as the next speaker. Zsuzsanna Jakab is the regional director for WHO in Europe. And as Michael already has mentioned, WHO have been really instrumental in terms of bringing these pieces and issues further and to gently try to push or nudge our governments into action on inequalities in health. Zsuzsanna was previously the founding director of the European CDC in Stockholm, and before that, Secretary of State in the Ministry of Health in Hungary. So please take the floor.
Thank you very much. Thank you for the welcoming words. Ladies and gentlemen, let me say that it's a real pleasure and honor for me to attend the 4th European Public Health Conference. My colleagues always tell me, don't share the same platform with Michael Marmot. But I have the big fortune to do it many times, and I never regret it, because it's very interesting that although we never coordinate our messages are always coherent with each other, and that is the great thing. He addresses the evidence, we address more the policy, but they go into the same direction. Ladies and gentlemen, I was with you also a year ago. And at that time, I spoke to you about the beginning of our work on the European Health Policy, Health 2020. I also spoke to you about the nature of disease burden across the European member states, with particular emphasis on the social determinants of health and inequities in health outcomes. I spoke of our present challenges, but also about the opportunities that are offered by more knowledge and by better technologies that we have today. I also referred then to my determination that all our work should be underpinned by evidence. I will talk to you today about the progress in the European health policy, Health 2020. We are well on the way to develop this policy, and we are consulting broadly both the member states as well as the other partners, and I'm very pleased to consult with you also today. As you may know, the European region of WHO has had a European health policy since 1980, since the regional committee in Fez, and I am building in this work on the excellent work of my predecessors. Today, I will talk to you mainly about the social determinants of health and also the concept of well-being, but then I will turn also to the other evidence that we are using for the development of Health 2020. Those who were there in Poznan recently have already heard some of my key messages, and therefore I apologize. So first of all, why do we need a new European health policy or an updated health policy? First of all, this is an era of rapid change in the nature of our societies, in the expectations of our citizens, in the main burden of disease. In addition, we have the financial crisis, which impacts on our decisions, and both the huge burden from the NCDs and also the financial crisis require a new policy thinking. At the moment, health across the European region is improving in overall terms, but not as rapidly as it could, given what is known and the technologies that are available to us. The European region still has extreme pockets of ill health and poverty, and also major inequities, as we heard from Michael, which need to be urgently addressed. These inequities are very significant, and to a significant extent, they are socially determined. The inequities also constitute a significant loss to social and productive capital. The inequities of health undermine the developmental potential of a country, both at the local and also at the national level, as well as acting as a concern in realizing values of health as a human right. Dealing with these inequities requires a focus on all the main determinants, including particularly the social determinants, and in my view, the changes that are required demand not only a new policy thinking, but also a new approach to health governance. And as these determinants lie across the whole of the government and the whole of the society, so must our interventions. We must align the financial, human, and environmental resources that will mobilize action for better health and organize our societies and governance arrangements for this. We have this obligation to human right to health of all of our citizens. At the heart of these inequities lie a mix of poor social policies and programs, low levels of education, and unfair economic arrangements. The lower a person's social position, the worse his or her health. The inequities accumulate over the life course and are often continued across generations, leading to persistent shortfalls in health and development potentials, both for families and communities. Further, there exists a systematic relationship between the socioeconomic position and health, and this is the social gradient that Michael has addressed. Reducing this health gradient requires a combination of broad universal measures with targeted high-risk strategies. We must deal with the causes of the causes, and as the Global Commission report said, the unequal distribution of power, income, goods and services, globally and nationally, that result in unfairness in the immediate, visible circumstances of people's lives. To deal with these inequities, a system-wide approach of governance for health is required to ensure that policy consistency across the government and all health-related sectors are present. Specific actions include systematically targeting public policies and private initiatives and aligning the financial, human, and environmental resources that will mobilize action on better health and well-being and its equal distribution in the society. Ladies and gentlemen, Health 2020 is about this. This is the vision of Health 2020, but now I would like to focus on another area where we wish this policy to be innovative in its thinking, namely the well-being. This is a more difficult concept than health or ill health. Yet, I believe the time is here for this concept. The famous WHO definition of health of 1948 has been many times criticized in the past. People said that it was too utopian. But I don't think that this is the perception now. I think this is the time for the WHO definition now. Let me begin by clarifying the issues a little bit. We have long spoken about health and health improvement, largely in terms of morbidity and mortality. Just as when we speak of human development, we often speak the economic language of gross domestic products, GDP per capita. These are clearly simplifications, yet data are reasonably available, and these simplifications encourage comparability and debate. Yet now we are taking a much more positive approach to health development in the WHO terms of physical, mental, and social well-being for our populations. Recent studies indicate that in those societies where there is a greater equality, there is also greater progress on a wide range of developmental issues. In the situation of our current financial difficulties, we need a new approach to developing policies and strategies for health and well-being and for creating the partnerships, infrastructures, and resources to ensure their implementation. We must all work towards the shared responsibility for the realization of health and well-being, which are essential in fostering economic development, poverty reduction, and overall social cohesion, both nationally and locally. This is a goal for our societies, as is the reduction in the inequities in health experience that I have just discussed. Again, here we need a new thinking of the governance of health and what has come to be called the whole of government approach. It is intrinsic to our thinking that the need for such policies and strategies must be understood throughout the whole of society and the whole of government, so that all those who must act fully acknowledge their responsibility and all available assets are mobilized. Ladies and gentlemen, I will now turn to an unprecedented effort that we did during the year with many partners to develop the evidence base to take forward this vision for Health 2020 and at the same time also to apply it in practice. So the first pillar of Health 2020 relates to the evidence on health equity. You heard from Professor Michael Marmot, who just spoke before me eloquently, on the necessity of dealing with inequalities in health as a moral and as a human right issue. Following on the work of the WHO Global Commission on the social determinants, you heard from Michael that I asked him to do a European study, and this work is ongoing. It is very well underway, and it will contribute to the thinking on the work of the European health policy. Our aim with this study is threefold. First of all, to provide evidence on the nature and on the magnitude of health inequities across the European region. Secondly, to synthesize the evidence on the most promising policy options and interventions in diverse country contexts in low, medium, and high-income countries in order to reduce the health gaps. And thirdly, to investigate the gaps in capacity and in knowledge. The reasons are very clear from looking at the differences in health across Europe and also the inequities revealed. We must keep health equity at the forefront of health policy making. This has been recognized, as we heard also, from the Global Conference on Social Determinants and Health, where a political declaration was recently adopted in Rio. It is especially so in Europe, which is a very diverse continent in terms of health outcomes. On this slide, you can see that in 1970, life expectancy was quite homogeneous. Now about 20 years average difference between the different countries in Europe. Health can be promoted and should be more equitably distributed in Europe, and this is why tackling health inequities is so central to Health 2020. As an illustration of how differences in life expectancy are socially determined, it can be seen that an increase in income inequality is correlated very clearly with a decline in life expectancy. This, as well as other evidence, implies that our new European health policies must address wider sectors and in a much more courageous way than we did before. We must address the policies of the whole government and involve the whole society, especially if we are to prevent widening health gaps, health divides in times of the economic crisis. This is why we encourage the European member states to develop their national multi-sectoral policies using Health 2020 as an inspiration, which will help them also to respond to the NCD epidemic and also through investment in public health, which is central to Health 2020, it will also help to mitigate the impact of the financial crisis. This leads me to the second pillar and line of evidence feeding into Health 2020. This is focused on the theme of governance of health. A study on this subject was presented to our regional committee meeting held in Baku, Azerbaijan in September this year, and you can find it on our website. Health can be approached from many different perspectives. It is a human right, it is essential to well-being, it is a global public good, and the promotion of health is the promotion of social justice. Every actor in society, in all sectors and at all levels of government, can be seen as having a stake in the co-production of health. Traditional models of health governance have focused on the management of health care and in the interface between providers and users of health services, between professionals and patients. Alongside this idea, a new concept is emerging, not only of the governance of health, but that of governance for health, a sharing of power and responsibility between all levels of government and all sectors and stakeholders and citizens. A practical example of this model is described in the so-called wicked problem of obesity. A major driver of the non-communicable disease epidemic, obesity, is a problem of both health and the other sectors. It is a typical issue where both the problem itself and its causes are systemic. and where solutions cannot be found in traditional linear models of direct cause and effect. Faced with such problems and potential solutions, the governance study proposes the idea of smart governance, which involves governing through collaboration, through citizen engagement, through a mix of regulation and persuasion, through independent agencies and expert bodies, and through adaptive policies, resilient structures, and foresight. These concepts are being incorporated at both philosophical level and at practical level, underpinning the Health 2020. A third pillar of evidence in Health 2020, made more urgent now in times of the economic crisis, is the compilation of a review of the economics of prevention and the cost of care. It is important to identify not only what works in what context, but at what cost. Otherwise, we cannot convince the political masters of the countries, the prime ministers, to buy into this concept. Overall, the evidence base and the business case for prevention is increasing, but there is a gap in knowledge, which we will close by the presently ongoing work in the European Observatory on Health Systems, working in collaboration with the OECD and ourselves. It is well known that ill health has a major societal and economic consequence, as well as a huge financial consequence on the health systems. This includes major economic implications from conditions that are largely preventable. If you just look at some of these figures, cardiovascular diseases has been estimated to cost 168 billion euros per annum in the EU 25, and they account for 60% of the cost of the healthcare systems. Similarly, the alcohol-related harm is estimated at 125 billion euros per annum. Obesity-related illness accounts for more than 1% of the GDP and 4.5% of health expenditure. And I could continue with similar examples on depression, cancer, road traffic accidents, and others. The ongoing study ranges across a number of significant areas related to health and well-being. A wide range of cost-effective interventions have already been identified and include both population-based and clinical interventions, and social interventions as well as medical. They will feed into the best buys to be promoted by the Health 2020 and related policies in Europe. A fourth and essential pillar of Health 2020 that I will highlight today is the strengthening of core capacity in public health and the development of a public health action framework as part of the health system strengthening approach. The Health 2020 policy and the health system strengthening approach provide the integrating framework for our work, through which the disease-specific work will be integrated. In the health system strengthening approach and the Tallinn Charter of 2008, public health was not visible enough. Therefore, we have revitalized, rejuvenated it, both in our office and in our work with the European member states. Governments are responsible for ensuring an effective level of public health services, as well as cost-effective healthcare services of good quality. To reflect this responsibility of the governments, they must ensure that certain essential core public health functions are carried out in whatever organizational form they have locally determined the health system. The functions are a vital component of a wider health system within society, giving expression to health across the whole political and administrative spectrum of policymaking. The delivery of these 10 essential public health functions shown here by the health system is a role and responsibility of all parts and all levels, and not only that of the public health institutions. So, for example, primary health care and hospitals have to deliver a substantial number of primary and secondary preventive individual healthcare services. Primary healthcare is particularly a key resource for providing health promotion, disease prevention services, which need very significant strengthening across the European region. And also, I would like to emphasize the importance of the setting networks like the Healthy Cities, the Regions for Health Network, the health promoting hospitals, workplaces, schools, and all these which have a very important role to play. As part of the development of the Public Health Action Framework, we have produced a web-based tool which countries use to perform a self-assessment of their public health capacities and services. It was tested in 17 countries, and it is now ongoing. The work is ongoing in Israel, Finland, Portugal, and Spain. Many of the EU countries are taking it on board. And as a follow-up, we will present a European Public Health Action Plan to our regional committee next year in Malta for adoption. And I would like to invite both UFA and ASFER and all of you who are sitting here in this room to be part of this process and important development. The European Action Plan on Public Health will be built around a framework for action. The key elements of that framework will look at all these issues that you see on this slide. Ladies and gentlemen, having sketched out the processes of conceptual development of the directions of Health 2020 and the evidence review, I will conclude my talk with a brief description of how these inputs are already being applied in action in addressing both non-communicable diseases and also infectious diseases in Europe. The burden of non-communicable diseases, as you know, is the predominant public health challenge in each of the member states of the WHO European region. Unfortunately, the European region and the Americas share the dubious honor of having the highest proportion of death from NCDs and injuries. Furthermore, in Europe, we have the highest overall smoking rate, highest per capita consumption of alcohol, highest proportion of dietary energy arising from fat, and the highest rate of raised total cholesterol. The burden of NCDs represents a major challenge for Europe, but we are also a region that has shown that these diseases can be brought under control, and even rapidly so. This year, we can safely say, is the year of NCDs. A regional consultation in Oslo set off the year. A global ministerial conference in Moscow came up with a declaration, which was then endorsed by the World Health Assembly in May this year. In September, our regional committee in Baku endorsed an unprecedented number of action plans on key health issues, and one of them was the action plan on NCDs. With the great support received for the NCD action plan, the member states of our region showed their readiness to step up implementation. And 1 week later, there was the United Nations high-level meeting on non-communicable disease prevention and control. Global leaders, presidents, prime ministers met in the United Nations in New York to set a new international agenda on NCDs. And I quote Ban Ki-moon, who said that the summit in September in New York is our chance to broker an international commitment that puts NCDs high on the development agenda where they belong. We have now started to work in the Global Policy Group with the Director General and the 6 regional directors to develop the roadmap for this UN high-level meeting. But it was wonderful to listen to your presidents and prime ministers to address issues of NCDs. Our joint NCD action plan, adopted at the Regional Committee in Baku, addresses diseases, risk factors, social and environmental determinants in an integrated and comprehensive way. It identifies specific action areas and deliverables to which member states, WHO, and partners can commit themselves over the 5 years of the action plan. The action plan takes a comprehensive and integrated approach to tackling NCDs in line with our strategy that dates back to 2006, and it was adopted also in the Regional Committee under the leadership of late Gudjon Magnusson. The action plan focuses on health governance, evidence-based interventions for the promotion of health and the prevention of disease, and the strengthening of health systems to increase their capacity to prevent and control chronic diseases. The implementation of all this work on NCDs will be greatly facilitated by the Health 2020. At the same time, we also apply Health 2020 to the continuing burden of infectious diseases in Europe. I don't want to go into this, but you know what are the problems. We still have a growing prevalence of HIV in the eastern part of the region. We carry 20% of the MDR burden, of the global MDR burden in Europe. We still have vaccine-preventable diseases, measles outbreaks. Last year we had an outbreak of poliomyelitis, but I'm very happy to let you know that the region has been certified again as a poliomyelitis-free region. Just to flag this up, that we agreed with our European member states, the 53 ministers in Baku, on a number of action plans for the communicable diseases, on MDR-TB, on HIV, and also on antimicrobial resistance. I was very pleased that Commissioner Dalli could be with us in Moscow during the MDG6 forum, where we jointly launched the MDR action plan for the European region. So in this presentation, ladies and gentlemen, I try to focus on our determination to Health 2020 to tackle health inequities in the positive sense of looking to health and well-being as an investment and as a success to our societies. I have also summarized our last years of work in the WHO European region briefly, both to develop the conceptual framework, but also to put it into practice. I would like to thank you for your attention. I would like to invite you to be our partners, both in further developing the concept, but also in implementing all this that we have jointly decided with the member states in recent years. And I wish you a great conference today and in the coming days. Thank you very much. Thank you.
Thank you very much, Zsuzsanna. Jakab, the fact that the WHO keep health equity on the top agenda is really very encouraging for all of us. I want to give the word to Torben Jørgensen, who wants to give a few practical informations.
Thank you very much. This is for the presenters tomorrow and the day after tomorrow about the poster session. Remember, this year poster sessions are moderated oral sessions, so you need to be prepared. So please, those of you who have a poster, please put it on a poster board now, this evening, or very early in the morning, tomorrow morning. And be there in good time to pick up the headset and the microphone, and also the chair for the poster session should be there in good time, so that it will run smoothly. These kind of sessions is going to take over from oral sessions in the future, so we should show that this can be efficient here in Copenhagen. And then for the oral presentators, please, those of you who have the first oral session tomorrow morning, go to the speakers room before the plenary session tomorrow morning to give in your presentations. And then only is left to say, enjoy the reception tonight and see you again tomorrow.
Yeah, yes. Stay here. There will be a next short session after this.
Ladies and gentlemen, thank you for all of you if you are staying with us for this very short and important ceremony for UFA and ASFAIR. This is an annual award, the Stampa Medal, the Stampa ceremony that ASFAIR and UFA present to a key individual who has made a tremendous contribution to public health. I'm happy to pass the floor to our new president of ASFAIR, Helmut Brandt, for this short ceremony.
Thank you very much. It would be great if you could be seated so that we can go on with this ceremony. Since we have this common European Public Health Conference, ASFAIR brought in this tradition of this Andreas Stampa Medal, and perhaps you know he was the founder of the School of Public Health in Zagreb. And that was in the 1920s, where the Rockefeller Foundation sponsored this kind of maneuvers in London, Belgrade, and in Zagreb. And today now we honor special people for this, and the engraving is Public Health Investment Harvests Rich Rewards. So this is really a true saying. And Andreas Stampa was called the man of action. But this time it goes to a woman of action. I'm very proud to tell you that this year Zsuzsanna, Jakab, director of WHO Europe, will be awarded with this award. But there will be now a laudatio before we give her the medal. And I would like to introduce to you Professor Rosa Adani from the University of Debrecen, who will give the laudatio for our medalist.
Dear colleagues, ladies and gentlemen, dear Zsuzsanna, September 20, 2003 is the date when the ASFAIR community first met Zsuzsanna Jakab at the annual conference in Granada. At that time, Zsuzsanna was the Secretary of State of the Ministry of Health, Social and Family Affairs of Hungary, and as the president of ASFAIR, I suggested to the executive board to invite her for the opening talk on the role of schools in public health capacity building in the low and medium income countries of Europe. She added to the title, Hungary as an example. I couldn't participate at the opening session as my only son received his medical diploma on this day in Hungary. I arrived to the meeting only in the evening. That remained an unforgettable one for me. Deans and directors lined up to congratulate me. I remember that one of them, the Dean of the Faculty of Public Health of the Riga University, Anita Villerusha, just simply said, "How lucky are you Hungarians to have such a Secretary of State who knows precisely what public health means, who appreciates the training institutions and their efforts in improving the quality of human resources in the field of public health, and in addition, who has such a nice personality." And Anita was fully right. We were very lucky. Zsuzsanna, as State Secretary of Health, managed the country's preparations for European Union accession in the area of public health between 2002 and 2005. She revived the national public health program on the basis of values and principles defined in the Health for All strategy of the WHO, and this period was one of the prosperity in the public health affairs of the country. The organizational structure of the National Public Health Program was elaborated. An intersectoral public health committee was established. Even at that time, she had talked about global health policy. The National Breast Screening Program, based on targeted invitation, was extended. A population-based cervical cancer screening program and health promotion programs for settlements, workplaces, and schools were launched, and the strategy against AIDS, as well as a national food safety program were developed. Zsuzsanna played a key role in this period in the negotiations leading up to the fourth WHO Ministerial Conference on Environment and Health that was held in Budapest in 2004. After all these prosperous years, we Hungarians were happy and sad at the same time when she moved to Stockholm to start working as the founding director of the European Centre of Disease Prevention and Control. I am fully aware that focusing only on the period when Zsuzsanna Jakab served as State Secretary of Health in Hungary doesn't do her justice. She held a number of high-profile national and international public health policy positions in the last 3 decades. She began her career in Hungary's Ministry of Health and Social Welfare in 1975, being responsible for external affairs. Exactly 25 years ago, in 1986, only one socialist country, Hungary, was represented at the International Conference on Health Promotion in Ottawa when the Charter was adopted with a delegation. And among its members, there was she, fully aware, even in that politically difficult period of time, that positive effects in health promotion can only be expected from internationally concerted actions, and people responsible for these actions of new public health should be present in the international arena. Between 1991 and 2002, Zsuzsanna Jakab worked at the WHO Regional Office for Europe in a range of senior management roles. As Director of Country Health Development, she was in charge of external relations and strategic partnerships, coordinating collaboration with the member states in the WHO European region and international partners. During her long tenure with the organization, she also served as Director of Administration and Management Support, Director of the Division of Information, Evidence and Communication, and Coordinator of the EuroHealth program. In the meantime, she improved her academic knowledge in the field of public administration, management, and public health. Zsuzsanna Jakab holds a master's degree from the Faculty of Humanities, Eötvös Loránd University, Budapest, a postgraduate degree from the University of Political Sciences, Budapest, a diploma in the public health from the Nordic School of Public Health, Göteborg, Sweden, and a postgraduate diploma from the National Institute of Public Administration and Management, Hungary. In 2005, Zsuzsanna Jakab became the director of the newly established agency of the European Union, the European Centre for Disease Prevention and Control. She started to work with 5 experts of communicable diseases, and when she left the organization in 2010, 300 professionals worked as her partners in developing the internationally respected Center of Excellence in preventing and controlling infectious diseases in the EU. Zsuzsanna Jakab took up her post as the new WHO Regional Director for Europe on the 1st of February 2010. She spoke in her address to the WHO Executive Board about her plans and ambitions for the coming years and called for a new European public health policy, one that raises the visibility of public health concerns on government agendas and transforms health into a joined-up governmental responsibility. The WHO Regional Office for Europe almost immediately started to work on a new, participatory and inspirational European health policy titled Health 2020 for healthier populations and more responsive health system. A draft policy framework was presented for the European Regional Committee in September 2011, and it is expected to be finalized in 2012. I am sure all of us highly appreciate Zsuzsanna Jakab's professional career and appreciate at least as much that while she was building this extraordinarily rich career, she could remain a supportive wife to his husband, who is one of the best surgeons in Hungary, and a good mother to her 3 children, by now successful adults themselves. It's been well known that the prestige of an award is defined by its awardees. The list of recipients of the Andreas Stampar Award shows that it is a highly prestigious one. And now I am asking the president of ASFER and the president of UFA, Professor Flahaut, Professor Ricciardi, and also the new president of ASFER, Professor Helmut Brandt, to make the award even more prestigious by presenting it to Zsuzsanna Jakab.
Thank you very much for the laudatio, and I would like to ask you to come to the floor. This is the medal, Public Health Investment Harvest Rich Rewards.
Wonderful. Thank you so much.
Your name is on it for
Oh, it is beautiful. Thank you so much. Thank you.
Thank you.
Thank you very much. Thank you. Thank you very much. Wonderful. Thank you so much. And thank you for the nice words. Thank you.
Congratulations.
You have to stay with me for a few more minutes for a short acceptance speech. Presidents, colleagues, it is with the greatest sense of honor and humility that I accept the award of the Andreas Stampar Medal in the field of public health from the Association of the Schools of Public Health in the European region. Dr. Andreas Stampar was one of the towering figures of the European public health, and it is the fulfillment of a dream to be given such an award in his name. I have, of course, read his inspiring story, and I'm sure you all have. He was a wonderful man. He was a brilliant pupil, an outstanding doctor, developing later an abiding passion for public health, as always combining knowledge with action. Excellent in both fields And by the age of 31, he was principal of the Yugoslav Health Service in Belgrade. He helped found an Institute of Social Medicine at the School of Medicine in Zagreb. And in 1927, he founded the School of Public Health in Zagreb with a grant from the Rockefeller Foundation. Later, he worked as an international expert for the League of Nations, working in both the United States and also in China. Then after the Second World War, as a professor of social medicine in Zagreb, he was president of the interim committee of WHO, charged with setting up its structures and constitution, and also establishing and developing the famous definition of 1948 of health with a focus on well-being. Professor Stampar was chairman of the first WHO General Assembly, World Health Assembly in 1948. He had an amazing career and he was a wonderful inspiration, spanning local, national, regional, global public health affairs. There is much in his work that remains as valid today as when he was alive, and I wanted to mention here two issues dear to him that I have taken to heart and kept very much in mind in my own work as a WHO Regional Director for Europe. The first, of course, is the need to strengthen public health at all levels and to achieve strong and effective public health services in all of our European countries. Just as he did, by public health, I mean always a combination of knowledge and action for health protection and also for health improvement. He was universally known, as we heard, as the man of action, and I would like to claim that view also for myself in my work when I retire from this job. With the strong support of the Regional Committee, my office is advancing the strategy and action plan to improve public health capacity and operations in the European member states. Here with my friends in ASFER, I must also make a wholehearted commitment to helping strengthening public health education as a necessary prerequisite for making the progress in public health capacity and practice here that we so badly need. The second issue is the idea of well-being. Dr. Stampar was there when this very positive notion of health was written into the WHO definition in 1948. And I am determined that we shall follow and lead when we develop the European health policy. I want health and well-being to be thought of as one of the guiding goals and principles of societies and governments. And I feel sure that Dr. Stampar would agree to that. I have looked down the list of my very distinguished predecessors as holders of the Andreas Stampar medal, and I see here many names that are known to me and whose work I greatly admire. This is wonderful company, and I am thrilled to find myself in the midst. It is a great honor that you have given to me, and I thank you most profoundly. I take my inspiration from all those wonderful contributions to public health, and of course, no one more so than Dr. Stampar himself. Mr. President, distinguished colleagues, members of the ASFER, I'd like to thank you from the bottom of my heart. Thank you very much. Thank you again. Thank you. Thank you. Thank you.
Thank you for accepting the honor, and by this we can close the session. Thank you very much for being here.